Welcome to the Dr. Franken Steve Podcast with your host, Dr. Frank Williams and Dr. Steve Snodgrass, MD, FACS, where we discuss a broad range of topics without limitations. Let's get to it. Here's Dr. Frank and Dr. Steve.
Hi, welcome. This is the Dr. Franken Steve Podcast. This is a continuation on our series of physician versus non-physicians. I'm Frank Williams. This is Dr. Steve Snodgrass. We're going to be covering pharmacists versus physicians today. So look forward to getting into this topic. And then the future ones coming up again are like art, health, and healing, as well as for young artists or old artists or artists that are unrepresented to be able to get into gallery representation. We have some coming up on a host of different topics, basically, from self-defense to everyday situations that are going on right now, the socio-political scheme of things, and kind of how to de-stress. We will be covering big pharma. We're going to be covering basically nutrition, health, all these different things. So we look forward to getting started. So Steve, I'll let you start right in.
Hello and welcome. As Frank said, this is going to be a discussion on pharmacy and physicians. And it's important because it's since the COVID pandemic, pharmacies have stated that they want a more active role in healthcare for vaccinations, testing, that sort of thing. So they're referring to some of these things as pharmacy first, test and treat, that sort of thing. So I want to go over this, and it gets a little complex, and I'll go through it, but basically, in my opinion, this really is not even arguable, but we're going to argue for the sake of argument, because we know we're going to be hit with a counter argument. And so we're going to state our piece, and we just ask that you do your own research. You listen to the podcast. We appreciate that. Then you go do your own research and make up your own mind after you listen to this and see how you would handle it. So what we're looking at is that the pharmacies here in the United States are making this big push for pharmacists to have an expanded role in healthcare and essentially, in my opinion, play doctor. So that's kind of what we're looking at. And they had put out a model where there were seven different conditions they were treating. But I want to go over two of them because, I mean, all of this gets rather bogged down and complex. But let's go, we're talking about sore throat and urinary tract infection. Those are the two that I want to go over because that's the ones that they're going to hit. Right. But if you look at the length of graduate level education, comparing a pharmacist that's 4 years of pharmacy school and for a physician that's 4 years of medical school, and the years of residency and fellowship training, there's no residency requirement for pharmacists, and for physicians it's 3 to 7 years. And the total patient care hours for pharmacy is around 1,700 to 1,800 hours. For a physician, it's 12,000 to 20,000 hours. So
Huge difference.
I would say it's more than a modicum.
Yes, and we need our pharmacists now. So as we're saying,
yeah,
they've got to be there because you don't want drug interactions that maybe somebody doesn't catch or that's been prescribed by somebody who's not up to snuff on knowing that, as far as, like we said, non-physicians. So
right. I mean, I think it's important that we know everybody makes up part of the healthcare team. We understand that, and we're not against pharmacists. We're not against physician's assistants. We're not against nurse practitioners. What we are against is that non-physicians taking a physician kind of role without any kind of supervision. That is our complaint. It's just like, hey, everybody's needed, but when you try to go out and practice medicine on your own and you're doing it without a license and you're trying to get a license, it's just not going to work. And you're going to see that, and you're going to see more complications, and you're going to see more deaths.
Yes.
That's my opinion anyway. So let's go over it. And I'll look at what's the physician education. I call it like a thought process. And looking at it first and foremost, physicians, when you're seen by a doctor, we are going to conduct a thorough history of present illness. It's called HPI, History of Present Illness. And we're going to go over everything that brought you to the doctor in the first place. Why are you here? And so we're going to talk about it. We're also going to talk about it. Does this apply to any friends or families that you've been around? You have some sort of potential contagious disease that you cause. So all of that is an important part of the history of present illness. The next, as we're taught to perform a comprehensive physical examination. And that's based on years of being supervised by an attending physician watching us do this. And then eventually, as time goes by and you've put in 12 to 20,000 hours, you get pretty good at it. So that's another thing. Next, which is vital, it's called forming a differential diagnosis. And what that means is, what could this be versus what is it? But you have to have all of these different things floating through your mind. It's just like, you know what? They come in with this kind of set of symptoms and signs. What is that indicative of? And then you have to narrow it down to what you think the actual diagnosis is. And from there, you order appropriate tests, and then you just proceed with care accordingly. Next, treating patients for a broad range of illnesses and diseases throughout the human life cycle, meaning from pediatric to geriatric, from womb to tomb, actually, in some cases, the womb itself. So let's look at that, and then let's look at what a pharmacist does in pharmacy school, according to what we've seen. And I should tell you that my wife is a pharmacist, and there's 4 generations of pharmacists in our family. So after this podcast, I may not be able to go home. But even I talked to my wife about it, and she's like, I don't want to treat a sore throat. I don't want to treat a urinary tract infection. I'm a pharmacist, and she said,
I can imagine with all the new drugs coming out, and with the availability of every time you turn the TV on, you're seeing drug commercials. We're one of, I believe, only 2 countries that allow all these drug commercials. So somebody sitting at home, especially whether they're a hypochondriac or they're having some symptoms, and they think, oh, I need to see my doctor, and I see this new medicine is going to take care of this. Or I can go online and do a televisit with somebody online that's then going to prescribe that medicine by either mail order or going to the pharmacy and picking it up. And that, like I said, that can be a slippery slope. You know me, I don't really like socialized medicine because it just leads into complications. Like I'll take Canada for instance, which ranks, I believe, the 9th worst out of 11 of the top industrial countries that offer that. And so what happens, their healthcare allows pharmacists here recently to treat about 13 different things so they don't have to go to a doctor, which they said helps cut down on patient waiting times and being able to be seen by somebody. I mean, it covers hay fever, oral thrush, pink eye, dermatitis, menstrual cramps, acid reflux, hemorrhoids, cold sores, impetigo, insect bites and hives, tick bites, sprains, and strains, along with UTIs or urinary tract infections. And my question is, are these pharmacists, which I love our pharmacists. I mean, they've always taken excellent care of us because of the family members and being the caregiver, as I said, for my 95-year-old father. The problem is staying in their lane. I want them to know everything there is about drugs, drug interactions, what works, what doesn't work. I don't know, where do they take a sabbatical and go back to school to learn these? Or is this something where they can take an online course for 10 hours, and now they're all of a sudden they're qualified to do basic emergency care, like through the urgent care systems I just don't see that, and maybe I'm wrong, but I don't think I'd want to go to my pharmacist and say, oh, you've got some acid reflux, I'm going to treat you. You actually find out you got throat cancer or something.
Well, here's what they're not trained for, and then from pharmacy school, this is what they're not trained for. So they're not trained to conduct a thorough history of present illness. So how many times have you gone into a pharmacy and like the pharmacist will sit down with you and go over all of these potential things? This is not going to happen, and they're not trained to make a differential diagnosis. They are not trained to treat patients for a broad range of illnesses and diseases in the life cycle. They are not trained to perform a comprehensive physical examination. So to answer that question, it seems to me like they want to do this kind of on the fly. And I don't know exactly what the training is, but I guarantee you this, it's not 12 to 20,000 hours. I can guarantee, to me, I may be wrong here, but it's more like the Acme. That's the way
From Looney Tunes?
Yeah, I mean, it's like, you can't tell me that you can gain 12 to 20,000 hours of training plus whatever that doctor gets in private practice and compare it to a pharmacist's experience of patient care. I just don't see it. So it's called test and treat. That's one of the things we're talking about. And I want to go over this. To talk about socialized medicine just for a brief second. I mean, that's what some of this is just trying to do, is just trying to push it down our throats.
Exactly.
Literally. But the thing of it is, they compare us to other countries and other things. Like, for example, they compare us to England. And I think the population of England is like 55 million people or something like that. We have 184 million diabetics and pre-diabetics in the United States. You can't compare us to anybody else. They can say like, well, let's look at United States compared to Canada, to England, to France, to Switzerland. I was like, we've got more diabetics and pre-diabetics than you have people. So,
yeah. Which is why we don't want those things coming into the U.S., because you're just going to make a critical situation even worse trying to bring people who haven't been to med school or spent the amount of patient care hours and treatments into that. That's my opinion, is just like I said, an advocate. I don't want to see that. I'd rather see where you're doing incentives to get more people into med school. And like I said, I don't have an issue with nurse practitioners or physician's assistants. We've had to recently change doctors for my family because our doctor retired and moved out of state, and loved him to death. And the thing is, the office we see now, you do have to see a nurse practitioner on your initial visit. And so, but I will tell you, as nurse practitioners go, and I've dealt with several, they are outstanding, and they are a great team. They're right there with the doctor. They go over everything every morning. They go out and ask the doctor questions. If you ask them a question, there's no arrogance there. They're very humble, and they're doing exactly what the nurse practitioners were originally set up to do.
Right, and like I say, there's no problem that it's the unsupervised part that's a problem.
Yes.
And I would like to say this again, this test and treat. I want to just relay something that happened to me as a third-year medical student, and that's the first year of med school where you actually are seeing patients. And I got singled out to answer these questions. And thankfully, I had been hanging around doctors since I was 14 years old. I'd been in surgery, a lot of surgeries, a lot of clinical situations before I went to college, let alone med school. But this doctor, he shows a chest x-ray, and he says, Dr. Snodgrass, which I felt good. He called me that. I really wasn't a doctor, like some of these people. And, I really wasn't a doctor, but they called me doctor, and I really felt good. I was like, oh, that sounds good, Dr. Snodgrass. But here's the thing. He shows me this chest x-ray, and it's a horrible looking chest x-ray. I mean, half of the lung is just gone. And he says, like, how are you going to treat that chest x-ray? And that is a loaded question. He's trying to trap me. And I said, like, well, first, we're not treating a chest x-ray. We're treating a human being. We're treating a patient, a whole patient, not a chest x-ray, not just a test, not just a chest x-ray. We're treating a human being. And he said, so how would you proceed then? I said, well, I would get a history of present illness. I would want to know, does he smoke? Has he been coughing up any blood? Has anybody around him been sick with anything that's similar to the symptoms that brought him here? Has he been around any kind of heavy metal toxicity or anything like that? I want to know what's going on. And then I'm going to conduct a thorough physical examination starting at the head and go down to his feet, because you don't know. And then eventually you probably will end up doing a bronchoscopy with brushing, sputum cultures for sensitivity, that sort of thing. And you're going to progressively work that patient up.
That's what I do.
There you go, exactly. But my point is if you're looking at that chest x-ray, the first thing you see, you say like, that is a chest x-ray that is consistent with small cell carcinoma of the lung, and it's time for him to say like adios, because you know that disease is pretty much incurable at the time, and it was a death sentence, not a diagnosis. Turns out he had a fungal infection and survived. So if you're just treating an x-ray, you look at what that kind of path would lead you down versus what's happening in reality. So I'm just saying other people don't have that kind of training. And that is the take-home point. You don't treat just a test. You can use the test as part of your whole assessment of that patient, but that is a human being that you're treating, and that's a human being with a family, and that's the whole point. So I do want to go over urinary tract infection, and it's a lot more complex than what you just think of. And don't want to confuse anybody, but the models that they're talking about using here in the United States are based on something in England. And then they're adding, it looks like, the best I can tell, I'm going through all this literature, it's a bit confusing, but it looks like they are going to use like a urine dipstick test here. Whereas in England, they said that a urine dipstick, the articles that I read saying a urine dipstick has been shown to have no value, which I disagree with that. But on the other hand, I'm not just going to treat a urine dipstick. I'm going to treat the patient. So let's look at that. For a history of present illness, you're looking at urinary hesitancy, which means you're trying to go, but you can't. Frequency, you're going more often. Urgency, you feel like you need to go, but you can't. There's suprapubic, which is right down by the pelvis. Discomfort, and there can be dysuria, which is burning on urination. I'm just kind of going through this to give you an idea of the whole assessment of that patient. And then on the physical examination, you may see some suprapubic tenderness around 10 or 20% of the time. And the diagnosis is ultimately made by urinalysis, which looks at the physical, chemical, and the microscopic portions of the urine sample, and then by urine culture. So, but according to the British model, the pharmacist takes you into a room, talks to you about your symptoms, and then decides whether or not to give you an antibiotic or not. And there's not a urine test. According to the literature I read, there's no kind of urine test or anything like that. It's solely based on a conversation, which to me leaves quite a bit to be desired, frankly. So that's what I'm looking at. Now, if you look at the urine test, let's go over the urine test, which is a dipstick urine. Now, let's just say that the United States model is going to use that. You have like this cursory discussion about, oh, I've got burning on urination, that sort of thing. And also they're limiting the test, or they're limiting the patient load on this in England to females 16 to 64 years of age, and they're calling that uncomplicated urinary tract infection. And I have a disagreement with that from the very beginning, because my question is, how do you know that's an uncomplicated urinary tract infection versus a complicated one, which we're going to go over. So there's a distinction right there. And in the United States, they may treat males as well. And just to give you an example of that, any circumcised male with a urinary tract infection is automatically classified as a complicated UTI. So the whole point of all this is look at what we're talking about, and none of this is being brought up by any pharmacy. So that's my point. And tests can be false negative, false positive. So you can't really rely on that test 100%. So there's a lot of things that go into that. And the most common urinary tract infection is caused by E. coli bacteria, and the National Institute of Health said that even if E. coli are present, 34% of the time, they won't show up in a test. So you just can't rely on it as your sole determinant. So I think that's one of the things that we need, again, to discuss. Now, what's so important about all this? The urinary tract infection that we're talking about is the lower urinary tract, that's the bladder, the surrounding structures. And the problem with it is that if it's treated improperly, it can advance to the upper urinary tract system, which are the ureters and the kidney itself. And I want to go over the differential diagnosis of a urinary tract infection. And I want to show it's not so simple as what you think. So here is the differential diagnosis for a urinary tract infection. Cystocele, which is a bladder cyst. Immunosuppression, the patient could have HIV, you don't know. Irritable bowel syndrome, sexually transmitted disease, poor hygiene, pregnancy, bladder stones, kidney stones, perinephric abscess, which just means that there's a pocket of pus around the kidney for whatever reason, but that can cause you to have urinary tract type symptoms, urethral syndrome, renal tuberculosis, a fungal infection, any kind of neurogenic bladder, any kind of uric acid or hypercalcemia condition in the urine, herpes simplex, heavy metal toxicity, vaginitis, appendicitis, bladder cancer. In a male, benign prostatic hypertrophy, prostate cancer, pelvic inflammatory disease, medication effects, overactive bladder, pyelonephritis, which just means that the kidney itself has an infection, recurrent urinary tract infections, complicated UTIs, which include abnormalities of the urinary tract anatomy, renal infarction, urethritis, uterine prolapse, renal or prostatic abscess, and renal failure. So you're telling me that pharmacist in that room is going to talk to you, and they're going to glean all this kind of information through a conversation, and then they don't even run a urinalysis.
Plus have the knowledge on every one of those or all of those to determine what it may be.
Yeah, everything that I've listed, I've seen. Everything I've listed, I've seen. And I would challenge any pharmacist, have you seen every one of those? And if you did, what'd you do for it? How did you treat it? So the other thing too that you have to think about is a physician, they're going to know antibiotic resistance patterns, because a lot of times the urine has been taken for culture and sensitivity, that sort of thing, and they can show resistance patterns. And if that happens, you're going to use perhaps a different antibiotic than you normally would, because now you're seeing that bacteria that was once treatable is not treatable by the same antibiotic. And so that is an issue. And the other thing that is extremely vitally important is a Clostridium difficile infection, which is it's something that happens when you get treated with antibiotics and you get an overgrowth of this certain kind of bacteria, and that can cause toxic megacolon, colon perforation, and death. And I have seen Clostridium difficile infection. I've had to operate on those people, take out the colon that has been ruptured and bring out a colostomy. So there's about 500,000 C. difficile infections per year, and they're related to antibiotic use. So you've got to take that into consideration as part of the treatment process. So you have anything you want to add to that?
No, other than, like I said, we're not against pharmacists, obviously, since Steve's wife for now, 40 years, before she watches the podcast.
I might have to skip this one. I might just you can watch the other ones, but kind of skip this one.
That way, yeah. So let's put Netflix on or something. But just like any of the specialties or non-physician services, everybody, and you'll hear me say this many times in many different podcasts, everybody has their own lane, their own role to play, like as Steve said, in the healthcare industry. Our goal is multifaceted. We want to make sure that we don't turn the U.S. into a socialized medicine country. That's one. Two, we also are big advocates for stopping scope creep. As I've said in a previous podcast about how many states are allowing, physician assistants, or rather NPs, nurse practitioners, to actually be autonomous and practice on their own. That I think that could just be dangerous. I would venture to say, look at some studies, which I know some have already been done, but look at the studies from the NIH and different places that's from the government within a few years, and I would love to see what those case studies are for the amount of patients that were treated versus errors and or serious errors. And so I think we're going to find that we have the best healthcare system in the world, bar none. We have access to healthcare that many other countries don't, many other patients around the world don't. As Steve and I often talk about, Steve always says, I can guarantee you if somebody's getting sick in another country and it's something they need an operation for, they're coming to the U.S. for that normally because they know we have the best healthcare system in the world. And in with that, there's research, there's labs that are doing experiments for newer medicines, for healthcare reasons. That's all great. The U.S. can do that. Under socialized medicine, that greatly gets retarded or gets held back because you cannot, under socialized medicine, they're not going to be able to get the private grants and everything going out there because the government's going to control every bit of that.
Yeah, and it's the thing about it is too, this is going away from the subject just a little bit, but I noticed it's about a week or so ago, I noticed where there was a spa, and the spa was providing these different treatments like I think vampire facial or vampire breast. So basically, it requires an injection and that sort of thing. But 2 patients came away from that being HIV positive, and one got hepatitis because the instruments were not sterilized properly. I'm going to say they just weren't sterilized. But the point is now you got patients who went in for some sort of cosmetic thing at a spa, and they come out with HIV positive. And that spa's been closed down for practicing medicine without a license. So I just want everybody to see that the trend is trying to get away from physician-led care, and it is extremely dangerous. And that's one of the points that we really need to make. And I did want to go over sore throat because sore throat is very common. And that's one of the conditions that they name that they're going to treat. And I want to show that it's not quite as simple as what you think. I mean, there's, again, there's a history of present illness. There's the physical examination and there's lab tests. Now, they're saying in England that, according to what I read, they said in that program that throat swabs were ineffective. And I disagree with that. I just disagree with that. I'm not saying that we're not going to treat just the throat swab. We're going to treat the patient. The throat swab is part of the whole process. But the way it is now, you do a rapid antigen test, and that's a swab, and also there's a rapid molecular test, but you have to know where to swab, and that's usually in the back of the throat. And so my whole thing is I'm sure they've been trained, there's been some sort of cursory thing. It was just like, this is where you're supposed to swab, and there's false positives and there's false negatives, and there's no telling what you're going to get with the acne. You don't know what you're going to get. So there you go. Yeah. And so, the thing about strep throat, antibiotic treatment is key, and it's highly contagious, and reinfection can occur. So all of this is extremely important because the complications of strep throat. And let's just go through those. Number one, a peritonsillar abscess. And that means like there is a pocket of pus back behind the tonsil. And I have seen that emergently. And that is an emergency because that abscess can grow so large it obstructs the airway. And so that has to be drained. And so like there is a saying from where, I'm going to say this goes back a long, long way, but where there is pus, let there be steel, because you have to go in and drain that abscess. You have to open that, and then you have to get rid of it, with a scalpel. So where there is pus, there must be steel. And the other thing is there's post-streptococcal glomerulonephritis. That just means that the bacteria can affect the kidneys to the point of kidney function being severely interfered with to the point of kidney failure. So that's an issue. Then you go into rheumatic fever. That's a condition where the bacteria it affects the heart, the joint, the brain, and the skin. And so if strep throat is not treated properly, that can occur. And you can also throw in rheumatic heart disease. And now with that, you're getting heart damage that hits the valves, and it can hit the heart muscle. The electrical activity of the heart can be interrupted. And so this can cause stroke and death. So let's go over the sore throat differential diagnosis. Again, is it a virus or is it bacterial? An important distinction that you have to make. And a lot of times you find that on physical examination because they're different. And allergies, that can do it. I've had that, of course, just from hay fever kind of thing, if you will. Pneumonia, scarlet fever, epiglottitis, infectious mononucleosis, rheumatic fever, herpes simplex, head and neck cancer. I have seen head and neck cancer present with a sore throat, gastroesophageal reflux, and peritonsillar abscess. Those are all in the differential diagnosis. And, I want to say that recently I became a grandfather. I am the G word, which at first I'm like, I'm really not old enough for this, but then again, I guess I am. So anyway, let's just say, for example, if my son and my daughter-in-law call me up and they say, you know what, our child is really, really sick, and he's got a fever and a sore throat, he's lethargic, I'm really concerned about it. And what do you think the likelihood is that I'm going to say, you know what, why don't you just run him down to the nearest pharmacist and get him checked? That's about a zero. That is a zero. And neither should you. Neither should you. What we're being asked to do is to, again, it's a push towards socialized medicine. And what we're being asked to do is accept less than. That's what we're being asked as U.S. citizens. We are being asked by certain powers that be to accept less than, because the quality of care is going to go down. There's absolutely, positively no question about that. And if this is allowed to happen, it's going to be interesting, to your point, what the studies are going to show in regards to what are the complications, what's happened to people, and how many deaths have resulted. And I can tell you that some of these people who are not qualified, they're not qualified to treat patients with no supervision. And what they're going to find out, what they are going to find out, and it's going to be at the most visceral level possible, when they make a mistake that causes a complication that can't be fixed or death, and they're going to have to look at themselves in the mirror on that. You can be cocky and you can be arrogant, but when you are, you better be great. That's all I can say. And the way things are right now is that you have people who are just absolutely, positively not qualified to treat patients unsupervised. They're not physicians. They haven't been to med school, but they think they are. And they're going to find out very different in all this process that I'm right. And I'll tell you this, when I was a med student and we were working in gross anatomy and we were working on cadavers, and again, I had been in different surgeries since I was 14 years old. And there was one of my partners, you're broken up into different groups, and you have partners in this gross anatomy lab, and this one fellow student of mine, he just said, and he was going to be an internist. He knew he was going to be an internist. And I knew I was going to be a surgeon, because then I've seen, hundreds of operations before I went to med school. And this internist said to me, you know what? He said, you're going into surgery, right? And I said, yeah, I know I'm going into surgery. And he said, this doesn't look all that tough to me. He said, especially when you talk about everything that you have to know as an internist and all that sort of thing. I said, well, your point is taken. I said, but I want you to understand this. Cadavers, they don't bleed, number one. So, that they don't bleed where real bodies do. And uncontrollable hemorrhage, you're hit with that and you have to stop it or the patient dies. That doesn't happen in a cadaver. And the cadaver doesn't have a family that's, for the most part, there's some things, but for the most part, a cadaver is not going to sue you. So you don't have to worry about that either. So there's a myriad of topics and things that you have to discuss when you decide what specialty you want to go into and what you want to do. But the point is, if you compare a physician's training to a non-physician's training, there is no comparison. So with that, that's really all I have to say, except I do think that we all need to contact our legislators and let them know about this. And if you're a physician, then
You need to get involved.
you need to get involved. And because many of my colleagues, I've talked to them about this, and they're so busy, they don't address it because they're just overwhelmed. And I get that. But, to substitute overwhelmed with a lower quality of care is no substitution. So, we have a lot of problems. I could go into it all day long in regards to, I think prevention is one of the, we could have podcasts on different prevention measures that would go on forever. Like, for example, falls are the #1 cause of emergency room visits, and that's $50 billion a year. And diabetes and pre-diabetes. You're looking at half the population has that. So the whole thing about our population and prevention, we can do a lot to decrease the cost of healthcare by preventing disease, because it's a lot easier to prevent disease than it is to treat it. So we want to cover all these things because we want you to be aware of it. We want you to think about it because it is going to affect you one way or the other. And so let's take a proactive stance and let's try to preserve the best healthcare system in the world.
Absolutely. As you were saying, not to expand on that, but with the busy lifestyle so many people have, and I don't want to say non-caring, but you have parents, you have single parents, you have caregivers, grandparents who were foster care or raising their grandchildren has been thrust upon them. And if they've got a good working relationship with their pharmacy, which a lot of people do, and then they see a brochure that says, "Hey, we can now treat these simple things," the slippery slope is that there's probably going to be a leaning towards them taking those grandkids or those children, or just going there instead of having to go and sit at a doctor's office where they maybe can't get in for a while, or instead of going to an urgent care, they'll just go down to their pharmacist and because it's something simple, they think. And as I said, I would hate to see those studies, even though they're going to come out, as the NIH has already done some for the government healthcare people that kind of overlook that and see what's going on and write about the different things. We're gonna be facing a critical point, which I think we're already at, as for scope creep and for socialized medicine. So, as Steve said, if you're a physician, a doctor, whether you're an MD, a DO, you need to really get involved, because I have several friends that are MDs and a couple of DOs, and after talking with them, psychiatrists, not for me personally.
That might be a consideration for you.
Yeah, that's true. I use them for when I have to deal with Steve. What happens is, majority of them, they've read about scope creep, or they've read about physician versus non-physician, just barely. They're somewhat aware of it, but they don't want to rock the boat, or they're so busy, they don't have time to really sit there and analyze it and look at where it's at, look at where it started, look at where it's at now, basically, and then where it's possibly going. And it's just going to create more and more havoc as we go down the road if it's not done in the way that it was originally meant to be done. So that's all I have, basically.
And I'm going to give the American Medical Association credit, because they've identified this and they are actively fighting it.
Yes.
And so I think, if nothing else, you join the American Medical Association to show the solidarity. And again, what we talked about, and I mentioned in the first podcast, horses versus zebras, when you hear footprints, most likely you can kind of get by with it. Is it a simple UTI? Is a woman coming in and she's 18 years old, she's got burning on urination, and you talk to her and you give her an antibiotic and you say, like, "How are you doing? Are you okay?" That sort of thing. And then it's treated. But what if it's not? What if it's not? What if it's one of those other things that I mentioned on that differential diagnosis? And then, like, all of a sudden, it's now you are behind.
Because it's progressed.
Yeah, now you've been treated for something, and while the antibiotic may have been a choice that a physician would have made, there could have been other things that the physician did. And you need to be monitored by that doctor, because what if it's something else on that list and they say, "Oh, well, statistics prove, that it's one and so, that so more than likely you'll just be fine." Well, what if it's you? What if it's your kid? What if it's your grandchild or anybody, a friend, family? It only takes one to really matter.
That's true.
So I just think that everybody needs to be aware of it. And again, we are not trying to start some war with these other providers, but we are in a war with people who are non-physicians, trying to act like they are doctors, and they simply do not have the training, they do not have the experience, and they do not have the knowledge base that a doctor has, period.
Well, with that, we thank you, and we look forward to seeing you at the next podcast. Have a great one.
Thanks for listening to the Dr. Franken Steve Podcast. If you enjoyed this podcast, please hit follow or subscribe on the link provided so you can stay up to date on new episodes. Until next time, stay healthy and stay safe.